Afternoon, everyone. It's so great to see you all on this very beautiful early spring day, still a little crisp in the air, but very sunny, and I love looking at it. I can see the outside and I can see all of you at the same time, which is the best possible view. So we are going to have a wonderful part two to our sexual health and intimacy as we age presentation. And I am going to turn it over to Susan Edgman-Levitan, who will give you all of the specifics about tuning in and introduce our speakers today. And I'm sure you'll enjoy this all. We had a lot of feedback from the part one of this. And for any of you who missed part one, Monique or Susan can tell you how to get it on YouTube if you got to miss it. So enjoy this wonderful meeting that we're looking forward to.
Great, thank you. So my name is Susan Edgman-Levitan. I'm the director of the Stoeckel Center for Primary Care Innovation, and I will moderate our call today. So a few housekeeping rules before we get started. Someday I'm going to do these as charades, but not today. So just again to review these quickly, we mute everyone to eliminate background noise, so you really can't take yourself off mute. You can view the speaker on your full screen, or you can go to the gallery view in the upper right corner and click on gallery view to see all participants. If your picture becomes jumpy or out of sync, click the stop video, the little video camera in the lower left corner to speed up your connection. And if you have questions, please use the chat feature in the bottom ribbon. And please know that we really want you to be careful about putting any personal medical questions on the chat, because anything in the main chat can be read by everyone. And if you do have a medical question, please reach out to your doctor. For this particular town hall, if you have a question that feels a little bit more private that you'd like to pose to our speakers, please send that directly to me. When you go into the chat, you can click and it says everyone, or it lists all the names. And I'm Susan Edgman-Levitan. So you can send it to me and I will ask the question for you. We really look forward to your questions and we'll do our best to answer all of them. And with that, I'm going to introduce our speakers today who are going to be talking with us about sexual health and intimacy, sexuality and intimacy as we age. So we're going to be hearing from Dr. Eran Metzger, who is the Director of Psychiatry at Hebrew SeniorLife and is also an assistant professor at psychiatry at Harvard Medical School. At Hebrew SeniorLife, his roles have included chairperson of the Ethics Committee, Director of Education and Geriatric Psychiatry for medical students, residents, and fellows at Harvard Medical School, and his academic interests include delirium, medical ethics in long-term care, and the use of balance groups to support medical providers. We're also going to hear from Dr. Rachael Falk, who is a psychologist. She's a clinical psychologist who specializes in working with older adults. She also is from Hebrew SeniorLife. She earned her doctorate of psychology at William James College, then completed an internship at a hospital in Wisconsin, followed by a fellowship in primary care behavioral health at the Bedford VA here in Massachusetts. She's been working at Hebrew SeniorLife since 2019 and provides psychological assessment and support to those at both Newbridge and the Charles in Dedham and Hebrew Rehabilitation Center in Roslindale. Her primary areas of interest are grief, anxiety, and sexual wellness for older adults. So with that, let's get started. Welcome to everyone.
Thank you, Susan. And Dr. Falk is going to put up our slides. It's great to be with you this afternoon. As you heard, this is part two of a series on closeness and intimacy as we age. Please don't feel that you needed to see part one. This discussion is a standalone discussion and will complement the excellent presentation by Dr. Connor. As you heard, Dr. Falk and I are psychologists and psychiatrists respectively. So while we're going to cover the same similar issues that Dr. Connor did, we're going to focus more on communication and relationship aspects, whereas Dr. Connor, as a primary care physician, focused mostly on medical. Next slide, please. So a brief overview of our presentation. We're going to talk about how to talk about closeness and intimacy, talk about changes in sexuality with aging, provide you some statistics, discuss some of the barriers that arise as we age and what we can do to accommodate those. Talk about challenges associated with finding a new partner later in life. And then finish up discussing some issues related to ethics and consent for sexual activity. Next slide, please. Well, we're delighted you're here because even though challenges around intimacy and sexual function are quite common, they rarely get talked about. So consequently, we don't get much guidance either as patients or even as providers on how to discuss these issues. In fact, a survey of physicians found that 85% received fewer than 5 hours of instruction as medical students on how to talk about intimacy and sexual function with their patients. So I'm going to hand off to Dr. Falk now, who's going to share some more statistics that illustrate the scope of this problem. And because it's a problem that is discussed inadequately, there arises almost a feeling of stigma around it that this type of discussion that we're going to have today will hopefully dispel.
Thank you, Eran. So given all those barriers and the stigma that was mentioned, who can you go to ask questions about sex? We know it's challenging to talk to your faith leaders or your friends even, and certainly your adult children for obvious reasons. So who do you go to? In a recent 2021 survey, about 17.3% of older adults spoke to their doctor about sexual health in the past 2 years, which I would say is a very little amount. And only about 2/3 of them had to initiate that conversation. Their doctors aren't initiating a conversation about sexual health after a certain age. So this is a struggle for people of all ages, all education backgrounds. And toward the end of this talk, we're going to be providing you with some resources that we think may be helpful for asking some questions. I wanted to come up with a couple of phrases, some questions that could kick off a discussion with your doctor or whoever else you decide to discuss sex with. So some examples might be, I've noticed some changes in my interests lately. What might that be about? I'm having some difficulty performing sexually, which is unusual for me. My spouse has early stage dementia. Will we be able to continue being intimate? And I'm not sure how or when to think about dating since my spouse died. So it can be helpful to know what is typical of most older adults. So the research shows that about 3/4 of older adults, 57 to 64, are having sex. And the number is about half of adults, 65 to 74, are still having sex. And by 75 to 85, still about 1/4 of adults are having sex. So it's actually about equal to younger adults, despite what people may think. Age and cognitive impairment don't actually remove our need to have intimacy in our lives, the need for touch, for relationships, for affection. But then again, not everyone has the exact same interest level. So if you're not one of the 73%, that's also okay. It's okay for younger adults as well to have different interest levels. So some people may be nervous about engaging in sexual activity as an older adult, especially if it's unfamiliar to you. And certainly there are risks, but they're actually pretty similar to risks for younger adults. So that includes STIs, which studies have shown have actually doubled among older adults in the past decade for a number of factors. People are living in more congregate settings, and it's a common misperception that we don't need to use condoms if there isn't a risk of pregnancy. Still do to prevent infection. And some older adults may be more prone than younger adults to have certain injuries or pain associated with sex. However, there are a ton of benefits of sexual activity and intimacy in general. So the first is the most obvious: pleasure. It feels good. It releases dopamine to engage in sex, and it releases subjective positive feelings. It also releases oxytocin, which is called the cuddle hormone, and it promotes a sense of bonding between two people. For both men and women, it increases testosterone, which can be protective against certain illnesses. And there's new data that's suggesting that increased frequency of ejaculation in men can be protective against prostate cancer, believe it or not. Sexual activity can be exercise. There's cardio. Sometimes there's strength involved in it. It's associated with less depression and greater life satisfaction. There's also a correlation with better cognitive scores. Now, that doesn't mean if you start having sex a lot, your memory will be better. But there is some sort of relationship between sexual activity when you're older and better cognition. It can help reduce loneliness and isolation. And for those who are in a committed relationship, it can help sustain that relationship.
So if you have experienced a challenge around sexual function, you're not alone. Sexual problems are quite prevalent, regardless of age. And we have a number of studies that consistently back that up. For women, sexual problems are reported in about 40%. This is both in the United States, but also worldwide, so it's cross-cultural. There are conflicting data whether with advancing age in women, sexual problems increase, whereas with men, even though the prevalence is similar to that for women, definitely we see a trend of increased in challenges around sexual function with aging. Next slide, please. And this is along the lines of a picture's worth 1,000 words. For men in particular, changes in sexual function, as I said, tend to increase in age. And one type of challenge is erectile dysfunction. And this slide illustrates that by age 70, which is the last bar over on the right in this bar graph, almost 70% of men experience some degree of erectile dysfunction. Next slide, please. So because, as we said, your medical provider may not her or himself feel particularly comfortable or even well-versed in how to talk about challenges around sexual function, you may be in the position of helping that provider start the conversation and structure it. And as part of our coaching of you for this conversation, we'd like to just review the normal human sexual response. The human sexual response is divided into what are called phases, and we'll run through those just quickly. Both across genders, males and females first enter a phase of excitement, followed by a period of plateau, and then for men, an orgasm, for women, possibly multiple orgasms, and then a phase called resolution. And this can occur in women with or without orgasm. And problems with sexual response can occur at any one of these phases. Next slide, please. And I'll review some general categories of changes that can occur with aging and how they affect different phases of the sexual response. As psychologists and psychiatrists, Dr. Falk and I are particularly interested in the effect of emotional problems on sexual function and intimacy. And these can include something as simple as over fatigue. We see this in some of our older couples where one member of the couple is a caregiver for the other and is exhausted. That can certainly affect essentially any phase of sexual function. Similarly, stress, depression, or conflict in the relationship will have an impact on this sexual response cycle. In women, menopause can affect the excitement phase, the plateau phase, orgasm, but also, and this is not a phase of the sexual response cycle, but I put it up here because it's important in the far right column, can cause pain during sexual activity, particularly sexual intercourse. A wide range of medications can affect any stage of the sexual response. Some medications that tend to do this more commonly are blood pressure medications. Even the medications that I prescribe to treat depression can unfortunately affect any phase of human sexual response. Similarly, medical conditions, and to name just a couple, diabetes, high blood pressure, various endocrine disorders can also affect multiple phases of human sexual response. And finally, surgery, for example, prostatectomy in men or hysterectomy in women, can most commonly affect plateau, orgasm, but then also result in pain. Next slide, please.
So if that all sounds really challenging, fear not, there are a lot of ways to adapt to these changes as we get older as well. So it was interesting to me to learn that back pain is actually one of the most common deterrents of sexual behavior. I think many of us can relate to having back pain and how much that can interfere with life. But there are other ways to be intimate if sexual intercourse isn't on the table. So for example, kissing, touching, holding hands, hugging, cuddling, naked or not, and what they call outer course or masturbation, whether mutual or private, can all sort of provide the same benefits that we discussed earlier. If the positions you had been using sexually before are no longer viable for you, there are also different positions that could be more accommodating. For example, spooning is a pretty gentle position. There's no pressure on knees. It's really easy to accommodate different belly sizes when you're on your side. Similarly, a missionary position can offer relief from joints, although if back pain is your problem, it may still be a challenge for your back. However, the use of pillows or wedges can be helpful in relieving that. And also, seated on a chair and facing one another, sort of similar to this couple pictured in the top left corner, can be particularly intimate facing one another, and it also can take some pressure off of the hips and knees. When all of these positions or intercourse in general do not feel like the right choice for you, There's also some fun in experimenting with toys, whether it's by yourself or with a partner. And I've included a picture here from the show Grace and Frankie on Netflix. If you haven't watched it, I highly recommend it. There's a lot of discussion related to this topic. And in this scene that's pictured here, Lily Tomlin's character and Jane Fonda's character are looking at the prototypes that they've created for a line of vibrators that are meant for women with arthritis because they're finding it so difficult to hold other toys. So there are plenty of accommodating toys out there if that's something that interests you. But one of the biggest takeaways I want you to have is that you may want to adjust your expectations as you get older or with different partners. If you're aiming only for orgasms, that can be more challenging and then more frustrating. But if you focus more on satisfaction or bonding, you may find that it's a more satisfactory sexual encounter.
We wanted to spend a moment talking about partnering as we get older. If we are searching for a partner, that can be more challenging. Technology, for better or for worse, has of course come to the rescue in the form of a number of different applications or apps that are designed to help. Just going to mute while my phone is ringing, excuse me. Find a new partner. And these go by names like, well, we have some apps that are specifically tailored for older folks who are looking for partners, and they go by names like Our Time, Silver Singles, and Match also has a separate platform for older partnering. There are also individual services where someone will meet with you personally to help you find a partner. These tend to be more expensive. If you are considering using one of these apps, we want to share with you some safety tips. Because social media has real benefits, but also some pitfalls around privacy and safety. If you are launching on a date with someone who you've met over one of these partnering apps, it's always wise to let someone know that you are headed out, where you're going, when you'll be back. It's wise to have a first meeting or first meetings in public places until you get to know someone. And don't be too quick to share with someone new personal contact information. These apps allow you to communicate without divulging personal contact information until you're ready. Next slide.
So there isn't a new slide on this one, but I wanted to briefly talk about the impact of cognitive impairment on sexuality and sex in general. So it's a misbelief that people who have cognitive impairments do not need the same things that other older adults do in terms of sex. There are actually a lot of benefits for people with cognitive impairments to engage in sexual or other intimate behaviors. Pretty much the same as the list I shared earlier: less depression, better life satisfaction, health benefits. But even more so than other older adults who are not having cognitive impairments, people with dementia need to feel some companionship. They need stimulation, a sense of security, feeling valued by another person, and a boost to their self-esteem, which are all concepts that may have gotten a little lost when their cognition declined. Living with cognitive impairment can be really scary and really lonely. And so engaging in some consensual and appropriate sexual contact with someone, whether it's their marital partner or someone else, can create a sense of home. It can help improve some sexual behaviors and be helpful for health and well-being in general. Now, Dr. Metzger is going to discuss briefly some behaviors that are associated with dementia relevant to this topic.
So as Dr. Falk mentioned, onset of dementia does not change our human longings for contact and intimacy, but dementia is not just a disorder of memory. It's often a disorder of communication and language. And communication and language are very important to intimacy, but not essential. So in sharing intimacy and sexuality with a partner who may have dementia, it's important to be attuned to nonverbal and non-language related indications of a partner's interest, comfort, and sometimes disinterest and anxiety around sexual activity. Cognitive disorders like dementia can also cause problems with control of sexual impulses, something we categorize as disinhibition. So a person who has a cognitive disorder may have decreased ability to control sexual impulses, and that may be something that you need some support with also from a healthcare provider. Furthermore, there are medications that, as we talked about, not only impair sexual function along the different phases of the human sexual response, but there are some medications that actually can stimulate what we call hypersexuality. And that can be a problem. And that's not a problem that you should have to deal with alone either in a partner, but to bring that to the attention of a medical provider.
So relatedly, it can be a little more challenging to assess whether the person you'd like to engage in sex with is consenting if they have a cognitive impairment. So I wanted to briefly go over what that means. When anyone, no matter what age, is considering a sexual activity with a partner, consent is always mandatory. And here are some examples of questions that are associated with consent. You really want permission, and consent can change at any point in the sexual contact, at which point it should stop. For people who are younger and cognitively intact, that is a little bit easier for us to communicate. For folks with cognitive impairments, it can be challenging to know whether or not this is their choice, whether they feel it's voluntary, whether they're entering into it knowing what they're getting into. So taking it back a further step, we want to know if the person has the capacity to consent to sexual relationships. So what does capacity mean? It's the ability to understand the behavior, to understand the risks of the behavior and the benefits of the behavior. The person would have to have the ability to make a choice and the ability to communicate that choice. And as Dr. Metzger was just mentioning, dementia can also impair language and communication. So there are nuances to be able to figure out if this person is able to do that. Someone can have capacity for certain things and not for others. So for example, someone may have capacity to consent to sex with their spouse, but not to manage their own finances. So it's helpful in these instances to have your provider, and best practice really is a team of providers of different professions evaluating the person to assess whether they have the capacity to say yes or no. long-term care facilities, skilled nursing facilities do have an obligation to ensure that you have private space for consensual sexual activity. That's something a lot of people don't realize is true. And that's because of all the stigma we discussed earlier. People don't advertise that it's a place you can go to have sex. However, the facility itself is hardly ever going to initiate to ask if you would like privacy to engage in sex. Most often people don't know how to react because there is inadequate training. And that's actually what I would like to talk about next. An initiative that I'm working on at Hebrew SeniorLife. I was recently certified in sexual health and dementia by taking a very interesting course. And after the course, I came back to our organization and said, wow, we really aren't doing our best to support the sexual needs of our older adults here. So I have since gathered a team of multidisciplinary staff, ranging from medicine, nursing, physical therapy, all across the board. And we are working on creating guidelines for our institution that are easy to follow at every level of care and across disciplines for how to promote and facilitate the sexual wellness of our long-term care patients, and to ensure that sexual activity is safe and consensual. We're working on reviewing cases that have already come up where we could be doing better, and trying to really change the culture of the stigma around our organization. Hopefully this will be a more global trend, that we can have these discussions, and that moving to long-term care or any congregate living setting does not have to be the end of your sexual needs. And as we mentioned earlier, we have a couple of resources for you. I won't go through all of them, but a couple I wanted to point out. The third one down, the mental health and aging, there are two websites there. They are both operated by Dr. Regina Koepp, who is a psychologist who specializes in sexual health for older adults. She has a ton of wonderful free resources on her website, including expert guides. She has a podcast where she interviews other professionals about topics related to sex and aging. She writes blog posts. There's just a lot of wonderful resources there. And right below, where it says referral directory, I wanted to point you to ASECT, which is the organization that certifies sex therapists in our country. I think it stands for the American Association of Sexuality, Education, and Counseling, something like that. And on their directory, you can type in your location and help find a therapist who is trained in sexual health in your area. Below that are a couple of medical specific resource guides on different websites. So the first is through Dana-Farber, where they have a support group for people who have undergone cancer treatment, which can affect your sexual performance and health. And then below is some information about folks with Parkinson's disease and Alzheimer's disease and how to go about intimate relationships. And here's where we want to pause and hopefully field some questions, have some discussion.
Great, thank you. I have to share with everyone, Dr. Falk, your picture of Lily Tomlin and Jane Fonda. I don't know if anyone has ever seen Lily Tomlin's one-woman show called The Search for Intelligent Life in the Universe, but if you haven't, it's worth finding. And one of the showstopper lines in it is where she talks about vibrators and describes them as hamburger helper for the bedroom. Even my very proper mother could not quit laughing when she heard that line. So with that, we do have a couple of questions. So I think this may be for Dr. Metzger, but could you say a little bit more? The slide you showed about the resolution phase, an ending. So what, can you tell us a little bit more about how that can be helpful for people to understand? What is it? When do you end contact? Whose or both is the question.
Yeah, that's a great question, because in men, the resolution phase is quite obvious. It's with the loss of erection, either with or without ejaculation. And there's actually another phase after that, which isn't included here, which is called the refractory period, which refers to a period after orgasm during which it is difficult for a man to have another orgasm, and the refractory period can last. It's quite different between individuals. There's not a normal amount of time there, but for women, both because they can have multiple orgasms and because they don't have as obvious an end of the excitement phase, it's not so clear when the resolution period is, and that's more of an emotional experience that needs to be communicated rather than something that's going to be obvious to the other partner. I hope that clarifies it.
Okay, if it doesn't, then please let me know. And we have another question that I'm going to ask you to read in the chat. I'm not sure I want to read the whole thing out loud, but I think it's a very, very important question, and hopefully either Dr. Falk or Dr. Metzger can respond. And it's from someone whose husband has Parkinson's.
Right. So it highlights that different conditions associated with aging can affect sexual function in opposite ways, can inhibit sexual function, but can also change it, can disinhibit it in ways that could be uncomfortable for a partner. Sometimes this is related to the medical condition itself, like Parkinson's disease, or even the medication that is used to treat that condition. And we know that one of the medications that's frequently used to treat Parkinson's disease can cause what we call hypersexuality. And there may be a need to make some adjustments in the medication, but a medical provider won't know that unless you report this to the medical provider. And unfortunately, the medical provider may not ask this during an interview. So you need to be the one to initiate that conversation.
I also wanted to add one thing that it's very common for depression and Parkinson's to be associated with one another. And having depression and or being treated for depression can change sexual interest. So it's possible that with adequate treatment, if there is underlying depression, there could be a change in that behavior or that interest.
And just for me to ask a question related to this, when you said it might be helpful to talk to the doctor, would it be helpful for the person who asked the question to actually go to the doctor with her spouse to be able to maybe have a discussion if that's acceptable?
Yes.
Okay. And I'm going to see if Dr. Levine or Dr. Russell would like to add anything.
I think one of the most important things is to untabooify the experience, because it, as we said last month, this is not something that is not a part of our life. It never goes away. And just like we have to adapt our walking when we have joint pain, we also have to adapt our sex lives, and it sometimes needs some external help and suggestions to troubleshoot that, so you can have the desired effect. So I just think that us talking about it, normalizing it as part of something you can expect with a conversation with us, and upskilling us in the resources that are available that Dr. Falk has shown us.
Thank you. And I have a question. Do we have, you listed a resource for sexual therapists. Do we have sexual therapists at Mass General or at Hebrew Senior Life?
We definitely don't have one at Hebrew Senior Life, I can tell you that.
Okay. Sounds like you're working on that. But I don't know if we do at, and I see that someone said, yes, we have them at MGH. And how do you find them? I don't know if Dr. Levine or Dr. Russell wants to comment, or the person who put that into the chat. Yes, you're muted. Monique, can you unmute Lorraine Drapic? You're
Hi.
unmuted. Hi.
So I run the sexual health clinic for the MGH Cancer Center. So
Oh.
there are 2 sexual health therapists here that I refer to in psychiatry, and they're psychologists here.
Is there a web link you can put in the chat?
And can you tell us their names?
Sure. They are Amy Clara and Lucy Finkelstein-Fox.
And if there's a web link or anything that you can put in the chat that might help people find them, that would be wonderful.
I don't know of a web link. Like I said, I have a direct referral to them.
Okay.
So I'm sorry, I don't have a web link.
Or maybe if you could just put their names in the chat.
Sure.
Great.
I've never got
Susan, I can say a couple of things. I totally 100% agree with Matt. I mean, talking about sex and issues around sex, it really normalizes it. But I often get this request. I often make these requests if I don't hear about them when someone comes in and with 100 bottles of vitamins that say, I'm having super tea and I'm using Dr. Sinatra's men's formula for this and that. And, and they come in, I'm not kidding, a shopping bag full of these things. And instead of, and then I bring this, I mean, I often bring it up on a first exam, not always, it depends on what's happening, but that's a trigger to me that, somebody is maybe having issues, or for actually for newly widowed or separated partners, that sometimes when I ask about that kind of thing, or it comes up, or sometimes people that have discomfort, it's real discomfort, but sometimes there's psychic discomfort along with that. And but it's really important to know that you can ask and bring it up, because I think the hardest thing is taking that step to talking about it. And our job is to really say, thank you. This is something we haven't talked about. And I'm so glad that you brought this up. And if you're on, Cialis, or, and you become your blood pressure drops every time you use it, but you really want to use it, how are we going to make that work for you? Cialis is a drug like, what's the other one, the other brand one that everybody uses? What, Matt? You're muted. Viagra, right. Those can dilate your blood vessels, and a lot of people get dizzy or feel crummy. And so it's really important, because sometimes these are things with complicated solutions, but sometimes there are things with very easy solutions, especially around all the things that medications can change.
Okay, so we do have a couple of other, Lorraine also added a comment that it's important to remember that sex is good for us. It creates vasodilation, which means your blood vessels open up, increasing circulation to our pelvis and sex organs. I don't know if Dr. Metzger or Dr. Falk want to say anything about that. And then we have another question.
I'd like to respond to the question.
Go ahead.
So the question was that this person's husband had an inability to have an erection in his 60s and never corrected the issue, and now into his late 70s, is it still worth addressing? And I feel absolutely yes. I mean, if there's an interest and there is a desire, and the inability to have an erection is the thing that's getting in the way of it, absolutely. It's not too late.
I'd also add to that sometimes that can be an important thing to follow up on from a circulatory standpoint.
Yeah.
So it should have a medical evaluation, certainly, and before initiating some of the treatments for erectile dysfunction, like the Viagra or the Cialis. You know, we'll sometimes have cruise ship people stopping off in Mexico, and we'll pick up the over-the-counter Viagra and Cialis without having had a medical evaluation. And so just to be safe, that's what we really do recommend.
Dr. Metzger, you're on mute.
Sorry about that. I would just refer back to that slide of human sexual response, and that there are various reasons why someone may have erectile dysfunction, ranging from emotional or even relationship issues to anatomical, to medications, to medical conditions. So it really, first, as Dr. Falk said, there needs to be agreement that this is a goal to try to re-achieve erections, and then taking a stepwise approach to trying to understand what the problem is, rather than just throwing a medication at it.
Okay, yeah. Any other questions? I don't see any others in the chat, but we do have a little bit of time left, so I want to make sure that if people have other questions, to let us know.
One thing we didn't talk about, and I think that this is something, you know, younger generations, the adult children of older adults, specifically those who might be cognitively impaired and in institutions, can sometimes have strong opinions about whether mom or dad should be sexually active. And, you know, I think I know the answer to this question, but I'd love to hear your expressions of how you manage this in those circumstances, because our families can sometimes be a peanut gallery that's uninvited.
Yeah,
That's
that
a
can
very
actually
diplomatic way to put it.
that can pose some real challenges, especially if a healthcare proxy is activated, or a power of attorney, and they disagree about how to go about it. And there's some famous cases from the news that involve issues just like that, where there's a discrepancy between the person's values and the values of the family. I think, Dr. Metzger, maybe you could speak to this as well. I think there is still some ethical conundrums about actually implementing like a sexual living will. I don't think it's really possible to do that kind of thing and actually have it, if it ever comes to a court case where there's a battle between the children and adults, I don't think it's something that could really be implemented. However, I think the theme of this talk is communication is important. I think communicating with your adult children, as awkward and uncomfortable as it may be, about how you would like to go about your intimate relationships when you are no longer able to make your wishes known, if that ever happens. The earlier, the better. We find it much easier to talk about how to manage your estate and finances than we do about our bodies. But our bodies are really personal and really important.
Yeah, this is definitely a new frontier in medical ethics. You know, in the previous century, physicians got much better at assessing ability to consent to medical procedures. And we are now trying to figure out what constitutes capacity to consent to sexual activity. And we're also trying to decide whether an activated healthcare proxy has authority over sexual activity. Is sexual activity a medical decision, or is it a basic human right?
I also want to add one other thing to really bring us to you know, it's a diversity, equity, and inclusion issue, which is that that people in the LGBTQIA population have many of these same issues that that everyone else has, and but there may be differences, or people who were closeted at one time in their lives may now have other interests as they get older. And so I don't think that we should make so many assumptions about people, because we just don't know. We don't know what people, this is an area that some people love to talk about, and they do love to talk about it. And there are other people who hold this very close to their heart. And but I think you know, if you know people or have contact with people who talk to you, or you're one of these people, it's really important that we hear that too. And it's something that people don't, you know, that people can forget about. But it's very, very important. And people grow and change throughout their entire lives. And which is one of the wonderful things about being a geriatrician, is to see how much people try new things as they get older. They have less things holding them back and inhibiting them from saying, what the heck, you know? So I think it's important to take that into account.
That's great. Thank you. So another question is, does Medicare or Medicare Advantage plans, do they cover sex therapy? Do you all know?
They should cover it the same as other behavioral health specialists.
Okay.
But
Okay.
if you have questions about that, you can always call the 800 number and ask for sure.
Okay.
And it would be important to make sure that the therapist who you're going to see is a Medicare provider, because not all psychotherapists accept Medicare, whereas many do.
Yeah. And also, is it best talking like with an example of someone with Parkinson's? Do you all recommend talking with the neurologist about this, with the medications, or a primary care doctor, or sex therapist, or all of the above?
Yeah, I would
What
say,
approach would you start with?
in the case of a neurologic disorder that's already been diagnosed, where you have a relationship with a neurologist, the neurologist will be very familiar with the effects of the condition and the medication on sexual function. And this assumes that you feel comfortable with this neurologist. I mean, this neurologist may be an excellent technician, but you may just not feel comfortable with your relationship with that person. So that would be a reason not to go to the neurologist. But if that's not the case, I would start with the neurologist, or if this is not a diagnosed neurologic condition, start with your primary care provider. Again, hopefully you have a comfortable relationship with that person, and if she or he doesn't have an idea of the process for addressing this, we'll be able to refer you to someone who does.
Okay. And then we have another question. If you see in the chat, I think frontotemporal dementia, and where consent and the memory might have a 15-second lifespan, and a person can forget that they've given consent or loses intimacy as well. So can you comment on that?
Yeah, I mean, something like frontotemporal dementia poses challenges in many ways. It's a really devastating illness, and there's no substitute for just getting to know the person and getting to know what his or her values were before the illness progressed to the point that that person can't communicate them consistently, trying to respect the previous values, but also protect dignity at this stage of the illness. There's just no general solution that we can offer today, but to have good relationships with your providers.
I also wanted to add a little something there. And as I discussed earlier when I was talking about consent can be given and taken away at any point during any sexual activity ever. Doesn't matter how old you are or whether you have dementia. It can be really tricky if that lifespan of how long that word lasts is 15 seconds. However, That's where it can also be important to know what the person's nonverbal cues are, that they are giving permission to continue engaging in a behavior that they consented to, and how do they communicate that they want to stop, even if they aren't able to verbalize it in that moment. So that's a very personal thing to discuss between you and your partner, so you understand their cues.
Okay. We only have a couple of minutes left. We don't have any more questions. So I just want to see if Dr. Levine or Dr. Russell have any closing comments you'd like to make.
Susan, I would just like to say how impressed I am by the questions, the number of questions, and their identification of just the types of issues that we're all trying to address in our medical practices. So thank you for those.
Well, I have to say, we are very blessed to have the amazing people that join our town halls every month. I think we're always impressed with their questions, and often stymied. Many people who attend our town halls are a lot smarter than we are. So it's been quite a wonderful experience for us as well. And I see Dr. Russell smiling. I don't know if you want to add anything.
I was just laughing at the fact some of the questions are actually like board exam questions that I would have to go to the library and study hard to answer effectively. But I do love our community. I think this topic originated from our community, and we'd love you to keep thinking what other topics you would like to hear, so that we can keep this series relevant and engaging. So that's my last plug. I think next month we're doing poetry.
Yes.
Yeah, so we're doing our second poetry slam next month. And so if folks are poets, amateur, professional, whatever, and you want to read your work, let us know, because our medical student, Ellen Zhang, who is a poet herself, who'll be presenting at the American Geriatric Society this May, will also be facilitating that next town hall. And as for those of you who were on the last poetry reading over the summer last year, the content was really very, very compelling and interesting, and it got all of our intellectual juices flowing. So that's just an open invitation for content. No limit.
Sure was. It was really fun, and we're really proud that Ellen's poster about doing that and doing poetry with older adults was accepted for a poster presentation at the American Geriatric Society. You guys this is why we love being geriatricians. Got to tell you.
And I think also, just to put in a plug for May, I think our topic in May is going to be, and this also came from you all, we're going to have a speaker. We have actually a center to address climate change at Mass General. And we're going to be talking about what we can do with climate change, what healthcare organizations are doing, because I think it's really important to understand that healthcare organizations are a tremendous contributor to the problems that we're having with climate change, which often is a big surprise to people. And it's one reason why many healthcare systems and organizations are really beginning to look at all of their practices to try to reduce their carbon footprint. So that's what we'll be talking about, I think, in May. But please send us other suggestions. I hope you have a wonderful rest of the day. It is chilly, and people are asking about how to get to part 1, which is great. Monique, do you want to put something in the chat about part 1, how to get that? It's on the MGH YouTube channel. And I think if you go there, you can just search for the February Geriatric Medicine Town Hall.
There it is.
Great. All right. Thank you, everyone. And thank you to our speakers.
Thank you. Thanks for inviting us.
All right.
Thank you.
Bye-bye.